I'm going to be recording the lecture for chapter 32. I actually did this once and I just double checked it and somehow the video only took the first couple of slides. This is my second time through. Hopefully this time's going to take. This first picture is obviously just a picture of a ventilator. Pulmonary embolus, that's where this text starts because this is a critically ill patient with respiratory problems. If you need to review things on the respiratory system, you can look at the 2 chapters back, I think it is, or chapter 27 is assessment of the respiratory system. If you want to review any of that or if you have questions, you can ask me. So the pulmonary embolus is when a clot travels into the lung from the inferior vena cava. It goes to the heart or the lungs, but we're focusing on the pulmonary embolus. It can go to both at the same time. The embolus comes usually from the lower body or the lower extremities or the pelvic area, but it can come from other places too. It can be solid, liquid, air. It can be a fat emboli. It travels through, that comes into the heart through the right side of the heart and into the lungs. And then as this picture shows, it just shows that dark area right in here, which says the area of infarction. It is more common than you would think. As the text says, there's 100,000 deaths per year just in the United States due to pulmonary embolus. That's the actual deaths, not the amount of occurrence. The occurrence is anywhere from 300,000 to 600,000 per year in the United States alone. The figures are that broad in between because they believe that many have gone undiagnosed or misdiagnosed. Multiple risk factors, which you can think your way through this. Prolonged immobilization. When you think about getting up and moving, most clots are in the lower leg, a deep vein thrombosis or a DVT. That comes from blood pooling. So the person that is immobilized for a long period of time, those muscles aren't moving in the lower extremities. Remember, your veins have little valves in them, and the muscles help promote that blood flow to pump that blood back up. So when you're not moving, that blood pools, and when blood pools, it has a tendency to clot. So people that are immobile due to advancing age, just not being very active, sitting in an airplane for a long time, having a long trip in the car, very, very important to get up and move. Important to get up and move when you're sitting in studying or something for a long time. Also, central venous catheters, they can be subclavian, jugular, PICC line, peripherally inserted central catheter that goes into the antecubital space, goes up into the central, to the subclavian area, into central circulation. They can build up debris, what they call vegetation on them. Things can be introduced through the catheter itself into that central circulation. Surgery, a type of surgery has a lot to do with, and other risk factors of the individual, the patient, when they're immobile for a long time, or if you're cutting through an amputation like bone marrow, certain fractures, different things make them more at risk. Obesity, advancing age, conditions that increase blood clotting. 2 of those offhand are smoking, because tobacco narrows the blood vessels and increases the chance for a blood clot to form. Also, hormone oral contraceptives, because the contraceptive increase the blood clotting. And then if you combine the two of somebody on an oral contraceptive plus smoking, the risk is tremendously high. Anybody who has had a blood clot in the past, of course, is at greater risk. Health promotion and illness prevention. just opposite of the things we just talked about. Another is this refrain from massaging and compressing leg muscles is true because you don't want to dislodge a clot. What you need to do is be preventive, wear compression stockings, encourage patients in the bed to move their feet, pump that blood in their legs. Anybody who's sitting, standing for long periods, wearing compression stockings during that time, and that's why you'll see them used in surgery quite often too. What are the clinical manifestations of having a DVT or a pulmonary embolus? The respiratory manifestations, which are listed in the chart 32.2 in your text, are obviously dyspnea, tachypnea, tachycardia. Tachycardia should be with a cardiac, sorry. Pleural chest pain, dry cough, hemoptysis. You will hear a pleural rub. That little link there, if it works, is to a little, I don't know if it's 30 seconds, very, very brief audio of a pleural rub. You will hear the rub on inspiration and expiration because it is the pleural lining that's inflamed and rubbing and has a coarse sound to it. Cardiac, distended neck veins because the pressure is building up in the heart. If you think about what's happening, the blood normally comes from the right side of the heart, goes through the pulmonary artery to the lungs to get oxygenated back through the pulmonary vein to the left side of the heart. So if the lung is not circulating, part of it is infarcted, the blood can't get through all the parts of the lung to be oxygenated. So some of the blood is actually shunting over to the left side of the heart without being oxygenated, and it also has an increased pressure in there, so you're getting some fluid issues and decreased blood flow perfusion to the left ventricle, so the left ventricle is not pumping as adequately. You're going to have abnormal heart sounds. Your textbook mentions an S3, S4, possibly that. You will definitely hear a split S2 because it's taking longer. There's a delay in the emptying, and you'll be able to hear both valves. We'll get into cardiac a little later. Anyway, so you can anticipate there might be a pulmonary hypertension from the previous scenario I gave you, and you might hear a galloping sound, but we haven't covered cardiac that much yet. Some general things that a person may present with is a stabbing pain, anxiety, expressing a sensation of impending doom. They might have petechiae on the chest and the axillary. Your text mentions that. Usually you're going to see that just with a fat emboli, but a fat emboli can also go into the pulmonary and be a pulmonary embolus. Some crackles, and possibly a fever. Diagnostic assessment. ABGs are arterial blood gases. I did post a link for you from a YouTube that goes over arterial blood gases. That's something you need to be familiar with. We're not going to get real complicated on them, but you do need to understand how to look at a blood gas and know if it's metabolic or respiratory. Is it acidotic or alkalotic? Is the body trying to compensate? A few slides from now, I'm going to go into the ABG numbers a little bit more. Pulse oximetry, of course you're going to be monitoring that. Initially you may not have drops in oxygen, but they will occur in time as the deficit expands. Some of the labs, your basic labs, looking at your basic metabolic panel, because you're looking for other causes of the respiratory symptoms. No labs or ABG are going to be diagnostic. D-dimer is a test. It can rule out, but it cannot rule in a pulmonary embolus. The D-dimer detects with some fibrin in the blood. Fibrinolysis is when the segments break off a clot, and it's detected in the blood in this test called a D-dimer. So if the D-dimer is negative, there's definitely no clot in the blood, so you definitely know it's not a pulmonary embolus. If the D-dimer is positive, there's some presence in the blood. It does not say there is a pulmonary embolus. It's not diagnostic, but it does help you warrant moving on further. Your text talks about troponin and BNP. We will cover those more when we get to the cardiac section. Imaging assessment. The imaging is diagnosed with the CT pulmonary angiogram. They inject a dye, do a CAT scan that gets imaging of the pulmonary arteries. That is the gold standard, or what the AMA is now referring to as diagnostic benchmarks. What that says is the best available test of that and should be the standard of care to use. There's another test, a VQ scan, ventilation perfusion ratio scan, that we used to use until we got better at testing. So a VQ scan may be done, but it is also not diagnostic and not the gold standard. Medical management. This includes anticoagulants. There is an excellent chart, 32.4 on page 607 of your text, talking about heparin, which is pretty much standard, giving an anticoagulant of heparin. It's an IV infusion that would be started, and after a few days they'll probably start an oral, such as a warfarin. But now there's some other medications out there where you don't have to do the blood testing for it, but in your text we're covering the things that are still out there that are used most of the time, or majority of the times. But heparin, for monitoring your heparin, you're going to do a PTT, or partial prothrombin time. With your warfarin, you're going to do a PT, or prothrombin time, with an INR, which is a ratio. Both of those, you want your results 1.5 to 2 times the norm, or your INR between 2 and 3 to be therapeutic. Warfarin is given orally. Heparin, I said, is given IV. Heparin is a continuous infusion. Needs to be very careful. It can cause a lot of bleeding problems. So that's part of your nursing interventions, is watching for the bleeding, not doing anything invasive. Usually they'll have a central line in that you can draw blood out of, or they may have an arterial line that you can draw your samples from, so you don't have to do punctures because of the bleeding potential. Also avoiding intramuscular injections. Using a electric razor to prevent cutting. What are the other ones? Oh, fibrinolytics are to break up the clot. TPA is the most commonly used. Great potential for internal and external bleeding, so that's when we get into your nursing interventions, is what you're looking for. Surgical management. It's very rare for them to do an embolectomy. They can attempt to do it percutaneously. Inferior vena cava filter. It can be put in. That's for somebody that has a recurrence of deep vein thrombosis that embolize. So it's to catch those in the lower extremities and in the pelvis. That's a fairly benign procedure that can see them done in the cath lab, where they just go into the groin area. Nursing interventions. Okay, so your interventions, if you think what I actually listed here are nursing implications, things that can occur, and what's that going to mean to the nurse, and how are you going to make your decisions on your interventions. So the chart is 32.3 in your text. Some of those things, hypoxemia, low oxygen, you're going to give them oxygen, whether it's a cannula or a mask. You're going to monitor the oxygen level. You're going to assess their lung sounds. You're going to check on their breathing status rate, all those things. Hypotension, that's due to the decrease in the circulating blood because of the left ventricle issues. You're going to make sure you have good IV access. You may be getting some pressor drugs to get the pressure up. You're going to watch the head of the bed. Often they will be on a cardiac monitor. Bleeding potential, you're going to be observing for bleeding. The text mentions doing, checking all the vomitus for, checking the stool for occult blood. That's not a routine thing. What you're going to do is look for Taria stools, look for an H&H that's dropping, watching platelet counts. You're going to test it or send it off to be tested if it has the smell of blood or is getting dark, or if they're vomiting and the emesis looks like there's blood in it. Looking in urine for any signs of bleeding, abdominal girth for internal bleeding, looking at their gums, that sort of stuff. Lab tests is the same thing, your PT, PTT, your INRs, your H&H, your platelet count, looking at your chemistry for your metabolic status. Anxiety, of course, the text gives you several measures to help with anxiety. You may or may not be giving medications for the anxiety. You want to help them at the same time. You don't want to suppress their respiratory effort. One I didn't put on here is neurological. You're assessing because they can have a chance of internal bleeding, so you're checking for signs of bleeding intracranially, or if they've thrown another clot, that they threw a clot to the brain. So you're doing your NUR checks, checking for headaches, all that sort of thing. Acute respiratory failure. This begins on the bottom of page 610. This is where it talks about your VQ scan, your VQ ratios, or your ventilation versus your perfusion. If there's any mismatch where they're not equal, whether it be the perfusion and or the ventilation, and you have an acute respiratory failure. Blood gases, your PaO2, or your oxygen in your arterial, will be less than 60. Normal is 80 to 100. Your PCO2 in your arterial blood is greater than 50. Normal is 35 to 45. And your pH is acidotic, less than 7.30, where your normal range is 7.35 to 7.45. Back over to your, over here to your SaO2, that is your oxygen saturation. Depends on where you look. This less than 90 for acute respiratory failure. A lot of places say your normal is 95 to 100. I say 90 to 100 because a lot of people with respiratory issues walk around with a 92 to 94. But the ideal is 95 to 100. So your SaO2 versus your PaO2. Your PaO2 is your oxygen level saturation, your oxygen pressure level that is in your arterial blood, where the SaO2 is measuring your hemoglobin, that's carrying capacity of oxygen, the actual oxygen molecules that are attached to the hemoglobin. The pathophysiology of acute respiratory failure. There's multiple reasons. Ventilator failure, oxygenation failure, or combined. The ventilation failure is anything that affects the ventilation. Physical problems of the lung and the chest, any kind of defect with your respiratory control, with the muscles, with your diaphragm. It can be an external or internal issue. Your oxygenation failure any insufficient oxygenation of the pulmonary blood at the alveolar level where the exchange has taken place. Ventilation can be normal when the lung perfusion can be decreased. There can be the shunting from the right to left with the VQ being off, like with the pulmonary embolus. Or there can be a combination, usually contributed to chronic bronchitis, emphysema, a severe asthma attack, a COPD person, somebody with some kind of diseased bronchioles alveolar with chronic lung diseases that has damaged it. The nurse's role is doing interventions for the dyspnea with the oxygen positioning, relaxation, doing measures, teaching the patient measures to conserve their energy. Medications may, sometimes corticosteroids are used, like prednisone. Sometimes it's helpful, sometimes not. It all depends on the underlying factor causing the issue. Acute respiratory distress syndrome. Key here, this begins on page 612. Key here is that persisting hypoxia. That's why I put those in bold. You can give 100% oxygen and your oxygen level's still not going up. That is a key that you are in ARDS, or acute respiratory distress syndrome. You can see the picture on there, the normal lung versus the ARDS. The ARDS is the pink puffy. We used to call it a white out on the chest x-ray. There is a systemic inflammatory response to injury. The injury can be multiple factors. Somebody without any pulmonary disease can end up with ARDS. Somebody with pulmonary disease is more liable to get it. It can be due to a severe pneumonia, some kind of injury, and it can, a lot of times a patient on a ventilator will end up with ARDS. The damage takes place in the alveolar capillary membrane. It becomes damaged. Things normally can't pass through. Large molecules cannot pass through, but due to the damage, large molecules such as proteins and fluid are able to pass through, so the alveolar get overloaded with fluid, causing that puffiness and fluid in the lungs. The ARDS also impairs the surfactant, so it's not adequate or working properly to allow that lung compliance or elasticity for expansion. So how do they diagnose ARDS? Their arterial blood gas, PO2 is dropping. The refractory hypoxemia, like I said, where you cannot get the oxygen level up, the whiteout noted on the chest x-ray. And I didn't mention on pulmonary embolus there will be some T-wave changes on your EKG, whereas with ARDS there are no EKG changes, so there's no cardiac involvement, unlike the PE. The low to normal pulmonary capillary wedge pressure, that's a measure you get if they have a catheter called a Swan-Ganz catheter in, and that all it's doing is giving you an indirect measure of the left arterial pressure. So again, there is no cardiac involvement. Interventions. Intubation, putting them on a ventilator. I loaded some videos from YouTube talking about the ventilator, the PEEP, the CPAP, all the different things. PEEP is positive end expiratory pressure. That positive pressure stays in the lungs constantly. Unfortunately, PEEP can lead to complications, which we'll talk about in a little bit. Drug and fluid therapy, the biggest drug is antibiotics, because this is often, if they don't have a pneumonia, they will have a pneumonia with the ARDS. So it's treated with that. They may do things trying to pull fluids off of the lungs with some diuretics. IV therapy, trying to manage that fluid, not to overload them, because the alveoli are already fluid overloaded. Nutrition is major. Any of these critical patients, somebody this sick, their metabolism is very elevated. They need to keep up their protein, their nutrition, their healing. Should have dietitian on board. Nutrition tends to get missed often. Case management can be involved, and that's one of the ones will help kind of keep all these things moving, keeping the case moving along like it should, covering these areas that sometimes get missed. As a registered nurse, it is your role to make sure this patient is getting what they need. A healthy, very healthy individual can go up to 14 days without having a deficit if they're getting enough fluids before they really are in danger nutritionally. But an ill person, it can be 3 days before their protein stores are gone, and they're going to start breaking that down in the lactic acid, causing metabolic acidosis and a whole realm of problems. So nutrition is imperative. If the gut works, use it so they can end up with a feeding tube and get feedings that way. Often this person is very, very at risk for aspiration, so they might be using a TPN during the worst times of it. Your text gives another section talking about case management. It's on page, I know I saw it, bottom of page 614, over onto the second column. It just talks about the different phases and case management. You might want to look over that. I'm not sure that I find that important. Okay, next slide. This is just a picture of an ET tube. This is it being taped. These two pictures, I chose them because it gives you both. This shows it going in the mouth. This shows the endotracheal tube going in the nose. Endotracheal tube, or ET tube, is what you hear it called. So it can go in either way. It needs to be held secure. Wherever the marker is, there's a marking on them as to the lip level or the narrow level that needs to be corded and monitored so that you know if the tube has moved. This little balloon is inflated. Once this is put in, this is inflated to keep it from dislodging. This little balloon out here is for the nurse to check, respiratory therapist to check to make sure this is firm, that it's not leaking, so the tube is secure. Although there is respiratory therapy that's very active now, and now they are much more educated than they were once upon a time. So they even have an associate or a bachelor's degree. They tend to be very territorial with their ventilators, but you as the registered nurse, if you are assigned to that patient, you are ultimately responsible. Even if physical therapy, occupational therapy, respiratory therapy are all coming in on the patient, ultimately you are, as the nurse, responsible. So you need to understand your ventilator, understand what you're looking for, how to fix the alarms, what the alarms mean, how to do your assessments, placement of that ET tube, reading the ventilator settings. All those things you need to have an understanding. I'm not going to go to the degree because you're not going to leave here being critical care nurses. You will learn it when you need it, but you need to have a basic understanding. Okay, next slide. Mechanical ventilation. There's just a few slides talking about the ventilator and different things, but I did find a really good YouTube short video explaining the ventilator, the different pressures, and the settings, the alarms on all of them. The next slide is more on the ventilator, the settings, the rate. These are the different things that will be set on your ventilator, and so that other video will go into that more. Nursing management. Always assess the patient first, the ventilator second. That is extremely important. You hear an alarm go off, always look at your patient, because sometimes the patient is in trouble, sometimes it's the machine and the patient's okay, sometimes the machine's okay, your patient's not okay. We had a situation many years ago where I went into a room, wasn't my patient light was on, I went into a room and the patient arrested as I ran in the room. A whole long spiel of things. I was a CVICU nurse. I had floated up to the step down. I called the code. I was in the room with the patient, so I called the code. The code team showed up before anyone on the floor even showed up. I didn't even have a crash cart in there with me. A couple of things happened. Nobody came in and assessed the patient. Somebody came to the door, peeked in, saw the patient seizing, went out and said, "Oh, it's just a patient seizing," which it wasn't. The patient was in arrest. The nurse was also a registered nurse, was on watching the monitors, was our monitor tech that day. She saw a normal sinus rhythm, which will make more sense when we get into the cardiac. It was actually PEA, pulsus electrical activity. It looks like sinus rhythm. It's just electrical activity. It looks like a beautiful sinus rhythm, but the patient is without a pulse. What had happened is the patient's septum had torn. He was a couple days post-op cabbage, coronary artery bypass graft, and so the patient did die. He would have died anyway. The problem was that everybody was looking at machines and nobody was looking at the patient. So it was a terrible, terrible, horrible situation to be in. So always look at your patient. Know how to manage it. Know how to fix it. Be prepared to do things. If they get extubated accidentally, the tube is up too far, you're going to know how to grab your ambu bag and go from there. Preventing complications is the biggest thing that the nurse needs to do, and we're going to get into complications now. Sorry, I needed to back up. Totally forgot. Obviously, when a patient is on a ventilator, their airway, they cannot speak because there is a tube in their trachea with pressure in there, so they cannot swallow and they cannot speak. They can't bring air past the vocal cords to form a noise, and they can't swallow. Mouth care is imperative, especially in preventing infections. You have to do a Younger suction out the mouth, and you have to find a way to communicate with them. You do have to keep their hands restrained so they do not extubate themselves. One, you don't want them extubated. Two, that's going to cause some damage with that balloon inflated, and you're going to have a big issue of the patient not breathing. But outside of that, for the patient's safety, you're going to have them restrained, and you can give them a board. That's usually what you do, is you have them write messages to you, and in time you can actually get pretty good with reading lips. Okay, so let me move on back to complications. Your complications are covered on 620 in your text. Also on 620, there's an excellent table, 32.5, on all the ventilator alarms. Okay, so on your complications, hypotension, low blood pressure, again because you've got this decreased perfusion. There may be a fluid issue with the patient, acid-base balance issues, that's with your fluid retention too. Sometimes the albumin is really low and they start third spacing, weeping out of their skin. Hypotension is also aggravated by some of your ventilator settings. If they have ARDS, the lungs are very stiff, so they do put the PEEP. Positive end expiratory pressure is one of the settings that will be on. The higher the PEEP goes up, the lower your blood pressure goes. When you have this end expiratory pressure in there, this increases pressure of the chest, so there's a decreased blood return to the heart, decreased cardiac output, resulting in decreased blood pressure. Gastrointestinal patients often, not just with ARDS, but on a ventilator, will develop ulcers. That's a common problem. So prophylactically, when they go on a vent, often they're given medicines to either decrease the acids or slow down that pump. So the H2 blockers, or to decrease the to decrease. Acid reducers are ranitidine, famotidine. They end in the itidine ending on the generics. The proton pump inhibitors are the azoles, omeprazole and esomeprazole. They all have that same kind of ending also. Nutrition I talked about, which is imperative. Infections, ventilator associated pneumonia, huge problem. There's lots of information in your text on this. There's protocols that have been written. Every hospital should have, I believe does have, your text refers to as the VAP or ventilator bundle, specific orders for prevention. It'll tell you about your mouth care, clearing out your tubing, how often you're changing your inline suction, multiple factors. Inline suction has been around for quite a while, which is very helpful because you used to have to disconnect them and suction them with a suction catheter, which was just a greater chance of introducing bacteria. Also, the initial picture on the ventilator, you saw those big tubes coming down. They get full of fluid because of humidity and water in the circuits, and if you don't empty them, you turn your patient, that dumps down, your patient starts coughing, and that can be contaminated and cause a big problem. Muscle deconditioning, because they are not moving. It is very important for doing range of motion. We now have physical therapy. I'm an old school nurse, and we used to have to do it ourselves. It doesn't make the nurse not have to do it. So be a good nurse. Do that conditioning, movement, range of motion on your patient, especially if they are either comatose or they may be in a drug-induced coma, so that they're not fighting the ventilator. A lot of times this person with ARDS, their lung is so stiff, non-compliant, and they have to put high pressures in the lung, so they will put them in a drug-induced coma using something like propofol or something like that, where it's easy. Propofol, you can turn it off. It has a very 1 minute half-life, so you can bring them up, assess where they are, cardiac, respiratory, neurologically, and put them back down. Ventilator dependence is also an issue that can happen, especially if it's chronic lung anyway, or there's really severe damage, because with ARDS, even though they may recover from this, there is permanent damage in the lungs. Once they've been once they've been on a vent about a week, if they're not coming off, at that end of that week, they will trach them to prevent further damage to the trachea. The two other things, the barotrauma and the volutrauma. The barotrauma can happen from the pressures used on the ventilator, and the damage is the same as somebody that does the deep sea diving. It's an actual rupture of the lung due to this forceful exhalation from the pressures of the ventilator, and it can lead to severe lung damage. It can lead to a pneumothorax, pneumomediastinum, which is a break right in the mediastinum into the pericardium. They can have subcutaneous emphysema. That's what I like to call Rice Krispies. For some reason, that's what it feels like to me. They get them up in the chest area, sometimes down in the sides, and you can feel the skin. It looks doesn't look bubbly, it just looks kind of puffed up, and when you touch it, you feel this crackly under your fingers, and that is subcutaneous emphysema. The other one, the volutrauma, again, is due to the pressure, but this is damage that occurs in the alveoli and the bronchioles of the lungs due to that excessive air into that area, and this overinflation or hyperinflation damages the tissue and due to improper, incorrect things or too high pressures on the ventilator. These next two slides are just pictures I put in here. I thought they were really good for helping you understand this barotrauma, the different traumas, what it's doing to the lung, what it looks like. This link here is to that site. Here's another. This is just FYI to help some people try to get a better grasp on this information. I just realized I had the on pause, and I'm not sure when I did that, so I'm backing up. I'm sorry if I'm repeating myself. A rib fracture, the chest is usually not splinted by tape. You want to try to avoid splinting the chest because you need them to expand their lungs. If they're not expanding the lungs, they get atelectasis and pneumonia. You want to manage their pain well because you don't want them splinting. You want those lungs expanded. There with the flail chest, it's a paradoxical chest movement. Paradoxical meaning the opposite of what's expected. So when you inspire, rather than the lung expanding here, the lung is going in. On expiration, rather than the lung going in, the lung is going out. And you see the mediastinum is moving, and the trachea is not staying midline, it's moving with the breathing because it's a sucking in from that. This is a picture of a tension pneumothorax. That's exactly what it is, where tension compresses right here. I found a little YouTube that does a really good couple of minutes explaining the pneumothorax, tension pneumothorax very, very well. The mediastinum does shift in a tension pneumothorax. What are you going to find? Obviously, asymmetry or unequal size of the chest wall, the trachea movement away from midline. It's toward the unaffected side. So if I went back, this is your affected side. So your mediastinum is moving this way. And I'm not sure if you can see in here where it's going a little to the side. Respiratory stress, obviously, when you have a collapsed lung, it may be part of a lung. It might be one lobe. It may be several lobes. Often, it's quite a bit. It's often due to something has caused tension inside to collapse that lung. Absent breath sounds on one side. That's kind of odd. The first time I heard one, I thought I was hearing breath sounds. I was hearing something. It's almost like this echo sound you hear from the other side. That's why it is so important when you do an assessment to go side to side so that you can compare, because it's this odd, you do hear something. It's only when you go to the good side that you can really distinguish that, oh my gosh, I don't think I hear breath sounds over there. There's distended neck veins. That's because of the pressure pushing on that lung. Cyanosis is obvious. Hypertympanic sounds on percussion. That's like a lost art. I'll be glad to show anybody how to do percussion. It's pretty cool because it should not be, you get this hollow sound, but instead of that you're getting this really high pitch that something's wrong. Hemothorax, it again is the tension, but it's from a blood building up and causing that. That's often due to a trauma. And I think that's covered a little bit on that little video that I found on YouTube for you. We are actually one more slide. This is our last slide, tracheobronchial trauma. That's pretty self-explanatory of what that is. Usually blunt trauma, often with a car accident. It can be a tracheal laceration, And the only thing you can do is do this cricothyroidectomy or tracheotomy below the level of the injury, because it is an upper airway obstruction. So you can't, it doesn't matter what you try to blow into that mouth, you got to get below that injury and get air in there. So hopefully between this, your text, and the couple little videos I found for you, you should be able to understand this chapter pretty well. And that is the end of this presentation.